think it's been almost 200 people between Facebook and the webinars.
Great.
Wow.
That's really good.
Here we go. Welcome back to our ANAwareness Week 2021 webinar series. We're excited to have you with us again today, or if you're just joining us for the first time, we're glad to have you here and hope that you'll join us throughout the week. Again, we want to thank Mayo Clinic for this great slate of presentations. And this afternoon, we're really happy to welcome Dr. Matthew Carlson and Dr. Michael Link, who are going to talk about quality of life outcomes related to vestibular schwannoma. They'll share some new insights into treatment-related decision-making and outcomes. I'll let Dr. Carlson and Dr. Link introduce themselves in just a minute, but I want to let you know how you can participate today and how this is all going to work. So first, everybody who is on the webinar and on Facebook is muted, so you're only able to listen. If you have questions, if you're on the webinar, you can go ahead and type them into the questions box. I think there's a Q&A button on your toolbar. If you're on Facebook, you can type them into the comments, and we'll be monitoring that as well. And we will, after the presentation, we'll try and get to as many of them as we can. There should be captions on the bottom of your screen. If you don't see those and you're on the webinar, there's a captions button in your toolbar, again, in your toolbar, and you can just click that to activate those. On Facebook, they should just be there. And we are recording this presentation. It will be housed on our ANAwareness Week landing page in the presentation section. We're trying to get all of today's presentations up tomorrow, but they're pretty big files, so it takes a little bit. We're working on that. You can always go right over to Facebook and watch those immediately to the ANA Facebook page. And there's lots of ways to get involved in Awareness Week this week. So check out the page on our website. You can just go to www.anausa.org and click on the link on the slider that's on the homepage, and that'll take you right to everything that you need to know about Awareness Week. So I'm going to stop sharing my screen right now, and I'm going to welcome Dr. Link and Dr. Carlson. Thank you so much for being here with us today. We're really grateful and excited to hear what you have to say.
Great, thank you very much. We're going to bring up the screen here. Maybe just let us know if you can see everything okay.
That looks great. Yep, everything looks great. Perfect.
All right, great. I don't know if you want to start with the introduction.
Sure. I'm Michael Link. I'm one of the neurosurgeons here at Mayo Clinic. Just like Dr. Carlson and the rest of our team, we have a keen interest in diagnosis and management of vestibular schwannoma.
My name is Matt Carlson. I'm one of the ENT surgeons here at Mayo Clinic. Like a lot of other large centers, we really enjoy our collaboration together between departments. We jointly see all of our patients together in clinic, and we discuss management options. A lot of the times the decision-making around tumors, in some cases it's pretty straightforward, but in many cases it's not. And just sifting through all of the information, which can be information overload, it's sometimes beneficial to have several people there just talking through it. And we also see the value of it just being in the same room also, because sometimes you worry about getting different messages when you go to different rooms or across the, the university or campus and see different specialties. So we hope that we can give you a unified advice or recommendation when you see us. But today for this talk, we're going to talk about quality of life in vestibular schwannoma. And I want to try to have us have an open mind or reframe some of the ways we think about things. If you ask anybody why they do something a certain way, they always say, well, it's because it's the way it's always been done. And a lot of times it's easy to not think more critically or I guess in a constructive, speculative way or constructive way to look at things to make sure we're doing things the best way for people and not just the way things have always been done. And so we're going to present a couple ideas that might challenge what we have always heard if you read a textbook or a patient brochure or something else like that. We'll have time for questions at the end. I think some of these things might be mildly controversial, and you might have heard different things. And if anything else, we just want you to start thinking about these things and understand how they might impact you with your diagnosis or your potential treatment choice. Just a couple things. We do have a book that we made at the Mayo Clinic, wrote at the Mayo Clinic. It has approximately 570 pages on vestibular schwannoma alone. And it covers all different aspects of the condition, from, why do they develop? What are causes of them? How do you think about treating them? How do you manage certain sequelae or complications or side effects of treatment or having the tumor itself? And so if you want a long book about a lot of different aspects of the condition, feel free to look at it. It's on Amazon. We also, if you're interested, we'd also encourage you to read a new article that we just published in the New England Journal of Medicine. New England Journal of Medicine is a widely disseminated general medical journal, and this is written primarily for frontline providers, primary care physicians, and such, that provides a really good overview of the condition, I think, without getting into too much detail, but providing just a very balanced discussion of all the different treatment options and what to expect through treatment and how we conceptualize or think about a lot of these different aspects. You do need a login to view it, but you can actually, if you subscribe for a guest subscription through a New England Journal of Medicine, they'll allow you to download 3 different articles for free. And so you can get access to the article if you want. It has some really nice pictures through the illustrators and such at the journal. So if you're interested, please take a look at that. Perhaps there's nothing more controversial than the diagnosis and treatment of a small or medium-sized vestibular schwannoma. We've seen in our research and other groups that if you go to one center, you might hear a very significantly different recommendation, or you receive a different recommendation from another center. And that's just because a lot of the information we have is incomplete or not. We don't have very, very strong evidence to drive a lot of our decision-making. And what's best for one patient based on their priorities or needs might be very different for another patient. And you'll hear a lot of statements said that are kind of historical and may not be really actually true or rooted in strong evidence. And those are some of the things we're going to go through today. In the early 1900s, the primary focus on treatment was just life preservation. People would present with very large tumors that were life-threatening, and the primary goal was to have them come through surgery and not have any major stroke or even death from an operation. Unfortunately, things have come a long way since that time, and now the mortality rate from having a vestibular schwannoma is much less than 1%. So it's not a diagnosis that you're doomed to have mortality, but it still does impose some significant consequences, particularly with regard to facial nerve outcomes and also hearing outcomes. Those are the most common things that we think about, at least as clinicians, primarily because they're easy for us to quantify, and we do feel like we have at least some control over those things with our treatments. Currently, for a smaller medium-sized tumor, you can have observation, which is the most common initial treatment for somebody with a tumor less than 1.5 centimeters in the United States. You could have radiosurgery, and typically radiosurgery could be offered to anybody reasonably so if your tumor is less than about 2.5 centimeters. And then surgery is an option for very small tumors, and just like all the other rest are, but it is the primary treatment for a very large tumor. So once you're getting over 2.5, 3 centimeters, most centers are going to recommend surgery, primarily because the tumor is causing enough pressure on the brain and a lot of those nerves. But really, the big question is, what is the best treatment for a small or medium-sized tumor? Historically, as clinicians, we've always said, well, let's look at our facial nerve outcomes and let's look at our hearing outcomes. Those are the most important things. That's what we will often say. But really, when we listen more to patients over the years, there's a lot of other things that can significantly impact a person's well-being, and not just whether your facial nerve is good or whether we preserve your hearing. Sometimes we'll be outside of a room after we operated, and our resident will go in there first and they'll say, oh, the facial nerve is normal. We'll get the audiogram and the hearing is really good. And we'll give each other high fives, or we feel really good about it. We walk in the room and we see the patient and they're having bad headaches, or they're having dizziness or something else afterwards. And that just goes to show you that there's a lot of things that can impact a person after treatment. It's not just those two things. Understanding that there's more to the story than just do we have tumor control, did we have a good facial nerve outcome, and did we have good hearing outcomes? There's been an increasing emphasis placed on quality of life measures. And quality of life is just a measure of your general well-being on a day-to-day basis. How has your condition or your diagnosis impacted your daily function, and overall, how are you feeling? And it's not just specifically honing in on one specific symptom. Over the years, there's been greater emphasis placed on this, and this is just a number of publications on vestibular schwannoma quality of life over the years. But what's interesting is when you just look at symptoms, we're primarily still focusing on hearing and facial nerve outcomes and giving less attention to some of these other things: headaches, dizziness, tinnitus, and depression. There's been several quality of life measures developed over the years. Most commonly, you'll see studies looking at using the SF-36 or the Glasgow Benefit Inventory. And more recently, in 2010, there was a measure called the PAN-QOL, which is a 26-item measure that looks at general quality of life for patients specifically with vestibular schwannoma. Overall, this measure is a significant improvement over just using the SF-36, but we, over the last 10 years of using it quite intensively, we've identified a couple areas that we think could be tweaked or improved upon. And so we've actually partnered with the ANA, and we're developing a new quality of life measure that we hope to get out in the next year or so, that we think will look a little more detail at a couple of specific areas that probably will impact patients significantly. So please stay tuned for that as well. So what really determines quality of life in patients with vestibular schwannomas? And over these slides, you're going to see a lot of numbers, a lot of graphs. Some people are really into the details, and some people just want to know big picture. So if you're more of a big picture person, just kind of listen to what we're saying. If you're more of the devil's in the details and you want to know the specifics, the numbers are there. But please don't try to get too distracted by a lot of the numbers and graphs. So what is the primary determinants of quality of life? Is it dizziness? Is it age, if you're younger or you're older? Is it bad headaches? Is it whether or not you have hearing? Is it the tumor size? Is it whether you have ringing in your ears? Is it facial nerve outcome? Other demographic features? Is it because you're a man or a woman? Are you more likely to have better or worse quality of life? There's a lot of these different things that we can look at. And for different diseases, it is different. And specifically for a vestibular schwannoma, that's what we first set out to ask. Like what things are the primary determinants of a person's overall quality of life? We performed a number of studies, we performed a number of publications based on some data that we acquired through working with our colleagues in Bergen, Norway, using the PAN-QOL, so the Pan-Acoustic Normal Quality of Life Inventory, as well as the SF-36 and a symptom questionnaire. And we surveyed groups in the United States and patients in Norway to get these data. These are some of the publications that came out of that work, and we're going to give you basically the punchline for this. Overall, there were about 550 patients that were surveyed, so a pretty large study for as far as it goes for vestibular schwannomas. The average time that people were asked about their condition was about 7 or 8 years afterwards, which we think is really important, because if you ask anybody right after treatment, or particularly after surgery, they're going to say something very different than they might say a year or two later. And so we always say it's probably better to wait a while before you ask people what their symptoms are or how they're doing. We looked at their demographics, tumor sizes, included all 3 treatment modalities, so radiosurgery, observation, and microsurgery. Most had poor hearing. And if you look at, you'll read online a lot about hearing preservation and different types of hearing loss with different management options. But if you take everybody in the world with a vestibular schwannoma, with or without treatment, the average person after they've been diagnosed for a period of time will develop non-useful hearing in their ear. And so in this study, most people had poor hearing at the time of survey, and most people had normal facial nerve function. Overall, there are a wide range of symptoms that people had. In this study, we looked at all the different symptoms, and the primary drivers of a person's overall quality of life was whether or not they had bad dizziness, or how frequent they had dizziness, and how frequently they had headaches. And so really bad dizziness is relatively uncommon. So having really bad dizziness is pretty uncommon, and having really bad headaches is pretty uncommon. But if you had those things, they were much worse than having facial nerve paralysis, or having hearing loss, or having really bad ringing. So even though it was uncommon, they had a significant impact on a person's well-being. This just shows how much it can impact the degree of quality of life based on your symptoms. So in the bottom right, again, don't focus on all the numbers, but focus in the area in the bottom right in that blue box. If you had frequent dizziness, your average score for your quality of life was 50. If you had no dizziness, your average score was 80. The best you can have is 100. So it's on a 0 being the worst you could possibly imagine quality of life, and 100 being the best. So you having dizziness all the time compared to none of the time, your score was 30 points different, which is really a huge score difference. And the same thing for headaches. If you had daily headaches, your score was 60. And if you had headaches less than once per month, your quality of life overall was about 75. And so big difference as well. This is just using the SF-36. So this is not as specific as the PAN-QOL, but just to make the point that it's the same story. We found the same outcome with this different measure as well. In just as in anything in life, the more times you see a similar outcome with different tests, the more you believe it's probably true. And this just shows dizziness and headaches were the primary predictor. And that just shows the magnitude of those factors on outcome. When we looked at, some people will say, well, okay, you're saying that headaches and dizziness are the primary predictors of bad quality of life, but what are the primary predictors of having a bad headache, or what are the primary predictors of having bad dizziness? So as far as headache, the group of people that were most likely to have headache or bad headache were younger age, patients with, or people with anxiety or depression or pre-existing headaches. This is really important because when you see a provider and you're thinking about different treatments, a lot of people say, I don't want to have surgery because I don't want to have bad headaches. Or they might say, because I have bad headaches, I don't want to have this type of surgical approach. But what we actually found out is it's not actually the surgical approach. It's not even the treatment long-term. It's more of these other factors. And so while it's true that maybe in the very short term, one treatment modality or one type of approach might have an increased risk of headache, long-term, which is the more important thing we think, that all of those treatment differences were a little bit of a wash, which might suggest sometimes we're focusing on the wrong things when we're thinking long-term about what treatment we should consider. So this is predictors of dizziness. So the predictors of having bad dizziness were being a woman, having older age, having a larger tumor size, or having pre-existing dizziness. One thing that's really come out of all of these studies on quality of life is we found that the primary predictor of how you're going to do later is how you're doing before. So if you are a person who has bad dizziness before a treatment, or bad headaches before a treatment, or bad ringing before a treatment, or bad hearing before a treatment, you're more likely to have worse, you're more likely to be worse off in that area afterwards, meaning a treatment is unlikely to dramatically improve those symptoms specifically. And so we usually say, don't let one specific symptom be the primary driver of your decision-making. There are rare exceptions to that, maybe facial pain or something else, but by and large, we say, don't let your symptom be the primary reason you choose one treatment. So we talked about what drives quality of life. I don't know if Dr. Link, if you want to talk about the differences in quality of life outcomes based on treatment.
So thanks, Matt. That's a really good overview. So what we really set out, I mean, the real underlying question we were trying to answer when we started all this many years ago is, okay, what's the best treatment? What's going to make patients the happiest? And as Matt mentioned, so we collaborated with our colleagues in Bergen, Norway, and we enrolled these 538 patients, and we asked them almost 8 years after treatment, how are you doing? And this is kind of the graphic representation of the data from the PAN-QOL, the disease-specific quality of life outcome. And just to go through it quickly, so we also included 103 just regular people walking around in the United States, and we asked them to fill out this survey. And one thing that's really interesting is those people who do not have vestibular schwannomas are in the light blue bars on this graph. And once again, 100 is the best score, 0 would be the worst quality of life you can imagine. So the higher the number, the better the quality of life. And you can see even people who don't have vestibular schwannomas don't have a perfect quality of life, right? We all have toenail fungus, or we get occasional headaches, or so on and so forth. And all of that in one way or another must affect our quality of life. But one thing that's been kind of interesting is in the yellow are all the vestibular schwannoma patients lumped together, no matter what treatment they had. And if you just compare the non-tumor people to the tumor people, you will see in most of the outcomes like balance, certainly like hearing, energy, facial nerve function even. People with tumors do a bit worse than people without tumors. So just having a vestibular schwannoma affects your quality of life. We certainly understand and appreciate that. And when you start to look at this idea of which is better, then you can break it out by treatment. So the red bars are the patients who had radiosurgery. The light green bars just had observation, and the dark green bars were treated with microsurgery. And you can see in some domains, like pain and facial nerve function, the green bars, the dark green bars, the microsurgery group scored a little bit less. And when you look at the total score, when you just ask, okay, who has the best quality of life? That's the last category there, listed as total. Well, people without tumors do better than people with tumors. But there's not much difference whether you have radiosurgery or observation. And statistically, because we had so many patients in the study, you could say, well, microsurgery did a little bit less. Their total quality of life score was 65, radiosurgery was 72. And it turns out when you do some fancy statistical analysis, that number is statistically significant. But we don't think that's the end of the story. So there's this way you have to look at it. On a 100-point scale, how much of a difference do you need for somebody to actually recognize that? So if I told you today that my quality of life was 85, and you asked me tomorrow, and I said, oh, my quality of life is only 80, is that really a statistical difference? Is that a meaningful difference? And there's some also fancy ways that you can analyze that, which we did. And it turns out that none of these statistical differences fit within the minimum clinically important difference. That is, all these changes in numbers don't actually make a difference. So the difference between a total score of 65 and a total score of 72 does not match the difference in an important quality of life. And all the numbers on this table just kind of show that when you compare the different treatments, there's really no clinically significant difference, which is quite surprising to us, frankly, that we took patients who'd had nothing done for almost 8 years versus patients who'd undergone a major intracranial operation versus patients who'd undergone a one-day radiation treatment, and they all end up about in the same basket. The main interesting finding, or the only really clinically important finding, I'll say, is that patients who underwent surgery seem to have a benefit in terms of the anxiety subdomain. In other words, for some people, getting the tumor out of there seems to provide a benefit in terms of anxiety. So this is now a different set of data. This is a different patient group that we prospectively followed. So before we've told you about patients that we just surveyed many years after they had their treatment. And we basically said, how are you doing now? So this is a group of patients that we started from the day they got their diagnosis and then have been following them now for more than 5 years with our goal to get at least 10 years of data. But this is some of our preliminary look at the data. So this breaks it down into patients who were just diagnosed. So that's the less than 6-month light blue bar. Patients who entered observation, patients who entered radiosurgery, patients who entered microsurgery, and then patients who've undergone multimodality treatment. Maybe they had a subtotal resection and then radiation, or radiation and the tumor grew and then we removed it. And surprisingly, once again, it turns out that the worst quality of life actually occurs when the patient first gets the diagnosis. It's quite alarming. It's quite disturbing to be told you have a brain tumor. Even if the doctor says, look, you have a small tumor, we can just observe it. There has to be a period of reckoning or a period of sort of getting used to that idea, we think. And this is most demonstrated again in the anxiety subdomain. The patients who are newly diagnosed have the most anxiety. It actually makes sense as we think about it, but it was a little bit surprising when we first looked at the data. And then when we look at patients who underwent treatment, what's really driving their decline in their quality of life? And which treatment is going to make that symptom worse? So we've learned that dizziness and headache are a big deal. And when you say, okay, well, which treatment makes that symptom worse? If somebody has a headache, we don't want to make it worse. And it turns out probably surgery results I guess not too surprising, and a little bit worse headache. But interestingly, it also scored in patients who reported their headache improved. Those were the ones who had surgery. So in some patients, headache gets worse. In some patients, headache gets better. And we don't yet, I would say, fully understand why that is. And then if you take people who had the worst headache starting out, so patients who before surgery said, yes, I have very bad headache, it turns out surgery tended to make that symptom worse versus radiation or observation.
So in summary, a lot of this data spans a lot of different studies, and these conclusions are based on those. But overall, patient-related factors, rather than treatment, most significantly influence a person's quality of life, meaning what you come to the table with or what the tumor has done already often predicts symptoms, meaning if you have really bad headaches before treatment, if you have really bad ringing before treatment or tinnitus, really bad dizziness, those sorts of things, it's hard to believe that the treatment itself is really going to significantly alter that course. And said another way, we don't think that in general, you should let one specific symptom drive all of your decision-making about something else. We'll commonly see a patient, they'll say, you know what, the thing that really, really bothers me is my ringing. And they'll say, if you can just take care of my ringing, I'll do any treatment you have. Which treatment makes my ringing go away the most? And it turns out that the treatment type does not modify that substantially. Or another way to say it is the treatment is unpredictable in its ability to modify that symptom. So I think that's different than what we'll commonly hear sometimes from providers, in that sometimes a person will say, well, if you're really dizzy, surgery is the way to go. It's almost always going to make your dizziness better. It does sometimes, but it doesn't always. And it depends on the type of dizziness, for example. Overall, constant dizziness and frequent headaches are overall uncommon, but when they are present, they have the biggest impact on people. And that's what our data shows, but we've also seen that. We've seen a person who comes back after surgery or after radiation, they lose some of their hearing and they say, you know what, it does kind of stink that my hearing has gotten a little worse, but I'm adjusting to it pretty well. And they have adapted to it. But then you'll have a small group of people that come back and they say, I have really bad headaches. And those are deal breakers for them. They can't go to work, or they have a difficult time going to work. They have a difficult time concentrating. It impacts them pervasively throughout their day. So while uncommon, headache and dizziness, when they're very strong or always present, they can have a big impact on a person's life.
I'll just also summarize by saying, you know, what it really comes down to, why we started all this is, I think like all doctors, we just want happy patients. And we tried to figure out, why are some patients really happy and some patients are not very happy? And probably many of you have seen, there was a recent article on the International Newswire, because countries get ranked. What's the happiest country in the world to live in? And the answer is sometimes surprising. And I'll even say, several years ago, Rochester, Minnesota was ranked as the best mid-sized city in the United States to live in. And when I read that article, I thought, that person has never been to Rochester, Minnesota. And they've never been to Rochester, Minnesota in January, I promise you that. But so it depends on what question you ask as to how you get the answer. But the happiest country in the world in 2020 was listed as Finland. And I don't know if you've ever been to Finland, but I would have thought maybe it was a really wealthy country, or a country in the Caribbean or something like that. And the reason why people think Finland, and it's often Scandinavia, it's Norway, Denmark, Finland, those are the countries that are typically the happiest countries in the world. And one of the big theories why that is because of expectations. So people in those countries know what to expect. And I think that's our key to getting happy patients, is if you know what to expect from each of the different treatments, then I think we'll have happy outcomes.
Well, that concludes everything. We're really grateful for the opportunity to present during this week through the ANA. We're also grateful for your time. I understand we have a really large number of people in attendance. And so anytime we can talk to you about something we're very passionate about is a good day for us.
Well, thank you, Dr. Lincoln, Dr. Carlson. That was a great presentation. we as an organization, and I know patients feel the same way, we really appreciate you taking sort of the focus past the surgical or radiological, radiation outcomes, and into what patients' lives are like following, long term. And so we're grateful for that and really appreciate that. We do have several questions. I have several coming in on Facebook and a couple here on our webinar as well. And we do have well over 150 people in attendance, so we're pretty excited about that. Somebody asked about the PanQOL and the SF36 tools, if those are available in the public domain. Is that something that people would generally use?
Yeah, so they are available in the public domain. The SF36 has been around for a very long time. It's a generic instrument, so it's used for back pain or depression or diabetes, or it can be used in any single type of disease class. The PanQOL is the first and only so far disease-specific quality of life measure that was developed by Schaefer et al. In 2010. Both are publicly available. As I said before, we are working with the ANA right now to develop a new instrument that will hopefully improve on some areas on the PanQOL, although I will admit that I think the PanQOL was a very significant improvement over just using the SF36. So those are available.
Interestingly, when we looked at our data, the SF36 had a hard time even figuring out who had a tumor and who didn't, because it's so generic. It has more to do with just a day-to-day quality of life. It didn't ask the specific things we were interested in, like dizziness and facial nerve and hearing and so on. But yeah, if you go on PubMed or Medline, you can get either one of those.
Okay. Can I ask you guys, can you stop sharing your screen, and then that way your faces will be bigger and that way it's easier for people when they can see us talking. Thank you. So you mentioned in your presentation that some types of dizziness respond better to surgery. What types of dizziness, what do you mean by that?
So interestingly, when a person says, vestibular schwannomas by definition come from the balance nerve. Mm-hmm. So everyone should be dizzy, right? If the tumor is coming from the dizzy nerve, shouldn't everyone be dizzy? The tumors grow slowly and they knock out the function of the balance nerve so slowly. And because you have multiple balance nerves in the same ear and the other mm-hmm. ear, most people adjust to it sufficiently well where they don't even notice it. So about half of people will say, I'm dizzy very temporarily when I turn my head quickly. That's very common, but very few people say I'm dizzy all the time. Mm-hmm. And so when we ask about dizziness, we specify, we try to really dig deeper and we say, how frequent is it present? What provokes the dizziness? And how would you describe your dizziness? So most people, when a person says, I am very dizzy all the time, that's usually not just the tumor. It can be, but it's often other things. And the old saying is, if you fix the wrong thing, you're never going to get better. So mm-hmm. if you say, well, I think the vestibular schwannoma is causing my dizziness, it's causing me to be dizzy all the time, most of the time you're going to find that after treatment you're still having some level of dizziness because there's something else to it as well. Dizziness is very common overall, just in the general population, and there's so many different causes of it. So if a person's pretty dizzy, before any sort of treatment, we usually get balance testing to really dial it in. There might be one specific group of people that benefit specifically from surgery for dizziness. And it's the group of people that have vertigo that's caused by abrupt change or more a quick change in balance function in that specific ear. And so sometimes doing surgery where you specifically intentionally cut the balance nerve so a person doesn't have the sick balance function where it's going up and down, and you give them something mm-hmm. stable to go after. It's always hard to adjust to a moving target. But if you can fix that target, some people can adjust to that a little bit better, but that's a little controversial. But I think the biggest thing about dizziness is if you're having really, really bad dizziness, there's a good chance it's more than just the tumor causing it. And there's a good chance that surgery alone will not necessarily make all of your dizziness go away. It does in some circumstances, historically, that we've kind of said that that's true, but it's not true all the time. That's one of the things that we want to, I think, is worth looking into. But specifically vertigo, might get better potentially with surgery, but again, it requires some investigation before anybody should really say that.
The other example is if you have a really large tumor pushing on the brainstem or causing hydrocephalus, then getting the pressure off the brainstem, relieving the hydrocephalus. But I think, just as Matt had mentioned, that most people with a vestibular schwannoma and acoustic neuroma at some point will have substantial hearing loss in that ear. I think most people say their balance is never quite normal. You know, whatever it was when we were all 16 years old and we never thought about our balance, it never quite gets back. It gets back to normal. But we like to tell patients, you know, if you work on it, if you stay active, you should be able to really do the things you enjoy in life, you know, ice skating, riding a bike, yoga, things that require still a moderate amount of balance. But you might have to work just a little bit harder at it.
Okay. So for patients who have radiation then and are dealing with dizziness, how do you help them get past that if there's not the option, obviously, to cut the vestibular nerve and let the other side sort of make up for it? How do you treat patients then?
So no matter what the treatment, whether it's radiation or microsurgery or observation, the best treatment, honestly, we find is vestibular rehab.
Okay.
So it's exercises to keep your balance system tuned up, find ways to move around safely in your environment so you're not a fall risk. Once again, when we specifically looked at dizziness in the outcomes, the treatment didn't matter long term. Everybody ends up basically the same place.
Okay. We had a great conversation with Dr. Weiskopf and Dr. Deep yesterday on balance and dizziness, and they said the same thing. And we talked a lot about how it's important to potentially continue to do that vestibular therapy even long term if you have to go back, or you do it for a while and you do things at home and then you go home, you may have to go back and kind of start over again, and that there are benefits to be had from that. So that is something we talked about yesterday. In patients that are observing, how do you determine when they should move forward with some kind of treatment?
That's a really good question. We
get it all the time.
I would say that, even a year ago, we would have given you a different answer. And 10 years before that, we would have given you even a different answer. And 30 years ago, we would say nobody should have their tumor watched. And so it's changing significantly right now. In general, if your tumor is about 1.5 centimeters or smaller in the CPA, we think most people are reasonable candidates for initial observation. And if you look at our center and you go nationally, I would say about 80 to 90% of the time, a tumor at that size or smaller, the initial recommendation is to observe the tumor and not treat it, only unless there's growth. If a tumor is larger than that size, most of the time we recommend just treating it up front. So we're talking 1.5 centimeters, not millimeters, 1.5 centimeters in the angle, so not including the IC part. That's an important distinction. But once it gets bigger than that, then you start entering this slippery slope of your outcomes being poorer when you get eventual treatment. And so if you're exceeding that size, we generally recommend treatment. There are some specific caveats to that. For example, it's rare, but there are some times when your tumor gets to a certain point or it might be causing symptoms that could improve with a certain treatment. But to answer your question more specifically, typically when we see growth of the tumor, we recommend treatment. And most people say what constitutes real growth is more than 2 millimeters on an MRI scan. Because if I scanned somebody's head now and I scan it tomorrow in a different scanner, you can't actually tell the difference between 1 millimeter or half a millimeter. But once you start getting over 2 millimeters, we say it's probably real. That's what you'll hear from most centers across the United States. And that's what we believe by and large. But what's interesting is it turns out that I don't want to make this more complicated than it needs to be, but basically tumors can start growing and stop growing and start growing and stop growing. So even if you had a tumor that grew a little bit, doesn't mean it's going to continue to grow necessarily. And so if you have an only hearing ear, or if you have, if you're, older, or there's something else that's unique about your situation, sometimes we'll even watch a growing tumor if it's small. So if your tumor is 5 millimeters and it grows to 7 millimeters, even though that's 2 millimeters bigger, we're not going to panic about it. We'll say, it could be still reasonable to observe it. But once you start getting over that 1.5, 1.7, 1.8 size, then we generally do recommend some form of treatment, because your risk goes up when the tumor gets larger than that. But up until that point, the outcomes are largely the same with a treatment. So long story short, we usually observe most of them under 1.5 centimeters, but once it grows 2 millimeters or more, on average, we recommend treatment. But there are specific circumstances where we still might watch it even.
Yeah. And does it matter what that time period is? Is that 2 millimeters over the course of a year, or 2 millimeters,
We like to compare our first scan we got, the diagnostic scan, to the most recent scan, because if you just compare year to year, you'll miss this really indolent or slow growth. So like, if you look at a scan from 2010 to 2011, it might have grown just a little bit, but if you looked at your 2000 scan to 2010 or 11, you might have seen that it actually grew over that time even more. It becomes more obvious the longer time interval. So we do compare to year, but more importantly, we compare the first scan to your most recent.
And most of the time when we're following patients, we do yearly MRIs, but after out, 5 years and don't see any growth, then we typically will go every other year. It's rare that we would go more than every 2 years on a patient observing.
One other thing that I think is useful is, so you'll hear a lot of different practices and different ways people approach them, but I would say overall, most of us are more the same than we are different for providers, but you'll definitely hear different things. Developed what we call a Delphi consensus document that was based on 16 different providers from across the country and even the world who are considered experts on this topic. And we went through what we thought was most reasonable, or what most people would recommend. And it goes through over 100 different statements, including, when do you treat, what size difference constitutes real growth, all these different things. So if you're interested in that, it is available online. If you typed in Delphi, vestibular schwannoma, and any of our names, it would come up in PubMed, and you'd be able to see those. I think those are pretty helpful. Those are guidelines. They're not what we'd call standard of care or legal documents. So somebody might practice or recommend something slightly different because of a certain circumstance or patient condition. But if on average, that's what most providers in the country would recommend for specific situations.
I think we're going to publish a summary of that you guys have written in either in our next newsletter or the one after that. But I think that'll, be amazingly helpful for patients, because I know that is something that they hear. We encourage patients to get multiple opinions from different doctors and different centers, and they do hear different things. And I think it can be just overwhelming. We had a question about quality of life changing over time. And I think some of the graphs that you showed sort of talked about that, but do you see that commonly with vestibular schwannoma patients?
So, we thought when we started to follow patients prospectively that the changes would be quite dramatic. Like, no question, it's a much bigger deal to go through an operation than a one-day radiation treatment or no treatment at all. But the changes over time aren't very significant, it turns out. I'm sure if we asked somebody, 2 days after an operation, their quality of life would be much, much worse than somebody that we're just observing. But, when you get out at the 6 month, 1 year, 2 year, 3 year, there's really not much difference. Now, the sad truth about all of this is all of our quality of life gets worse as we get older. I had a birthday yesterday. I can attest to that.
Well, happy birthday.
Thank you. A shameless plug. And I think patients have to really realize or accept that there's a lot of things that affect our quality of life. So we often do see patients who we've taken care of and are following, or maybe we didn't treat at all and we're just following, who come back and have a variety of other symptoms that we say, we don't think this is related to your vestibular schwannoma. And so you have to kind of keep the big picture in mind, I think.
We talked about the differences in quality of life based on the different, the three main treatment options: observation, surgery, or radiation. Does the PanQOL, does it measure at all the differences in outcomes between the three main types of surgery? And do you find that there are certain symptoms that last longer with each different type?
We did actually look at that. So in our group between Mayo Clinic and Haukeland University in Bergen, we do all the different surgical approaches. And one of the kind of, I'll call it a myth, was that retrosigmoid craniotomy results in bad headache. That's kind of been out there on the chat rooms for a long time.
Yep, we hear that a lot.
And it turns out that, as Dr. Carlson had mentioned, the surgical approach, middle fossa retrosigmoid translab, did not affect headache long-term. It was patients who had a lot of headache before surgery tended to keep a lot of headache after surgery. Similarly, when you just look at the hard data, like facial nerve outcomes, no difference. That all has to do with tumor size. So people with bigger tumor have a bigger risk to their facial nerve. Obviously, you can preserve hearing with middle fossa and retrosigmoid. You can't with translabyrinthine. Again, in terms of dizziness, no difference, no matter what the surgical approach was. Tinnitus, no difference, no matter what the surgical approach was. It's a really interesting, good question, I think.
We've had quite a few questions on new treatments, whether that's for tinnitus. Somebody asked about tinnitus and said that they have that ongoing, and if there's anything on the horizon to really help with that, since they're really, other than, just sort of not thinking about it, there hasn't been a lot of help there. But then also even major treatment methods to treat vestibular schwannoma in general.
Yeah, the tinnitus question is a good one. Overall, so currently there's no FDA approved pharmacological treatment, so medication or surgery to treat tinnitus. Mm-hmm. When a person has tinnitus, the first thing we ask is, well, are you just telling us so that we're aware, or is it actually very disruptive for you? That's a big difference. A lot of people, tinnitus is actually pretty common. About 1/5 to a quarter of the United States adults have some level of tinnitus, either coming and going or constant. Yep. In one ear or both ears. And for a lot of people, they know it's there, but it doesn't bother them significantly. But then for a subset, they're really distracted by it on a daily basis. It interferes with their ability to work and sleep. And those are the questions we try to ask. The first question is it distracting, significantly distracting for you? Then if they say yes, then we start talking about treatment options, but there's no cure for it. The treatment options for tinnitus, most commonly, if you have some hearing in that ear, it's masking. So by introducing a different noise into the ear, you can actually distract or cover the ringing, and that helps people a lot. There's also more informal ways to mask. As you're going to sleep, you might turn on the fan, or it used to be that you turn your channel to channel 3 and you get static. Now it's different. You don't have channel 3.
Do that anymore.
You can do white noise background, that sort of thing, like one of those noise machines. One of the more difficult situations is really bad ringing in a person who is deaf in that ear, because you can't introduce noise into a deaf ear. You cannot mask a deaf ear. And so what's interesting is people always say, well, if you had just I don't even care about my hearing anymore. My tinnitus is so bad, just cut my hearing nerve, so I don't hear this anymore. It's a little bit like phantom limb pain. The issue is not generated, the issue does not rest in the ear. It's the brain's perception of what the ear is doing that's the issue. And so even if you cut that nerve between the ear and the brain will continue to generate noise, and you'll perceive that as a noise in your ear, even though it's generated by the brain. And so even if you lose all your hearing, you can still hear ringing. In fact, you're more likely to have ringing if you can't hear. And so that's the hard group, because you can't introduce noise into that ear, because that ear cannot hear anymore. A small percentage of people are candidates for cochlear implantation in that setting. Actually, oddly enough, cochlear implants have always been just for people who couldn't hear very well, right? But oddly enough, we found out that cochlear implants have the ability to reduce tinnitus in a subset of people. And I want to make an important statement right now. This is really critical. I would not call it the mainstream treatment for ringing. So if you're on here and you say, I have ringing, I want a cochlear implant, it's much more complex than that. You'd only do it if you had poor hearing, very poor hearing, and your nerve was intact. And then there's insurance barriers and everything else, but it is an option in a select group of people. So I want to make sure that if you say of all the people who have ringing in their ear and who have a vestibular schwannoma, less than 0.01% have a cochlear implant. So I just want to make sure that you don't say, well, there's my solution, I'm going to get that. It's not that straightforward, but it could be an option for some people. With regard to, so that was the question about ringing or tinnitus in the ear. The other question was,
any new treatments down the road for vestibular schwannoma. And I would say not really, frankly. We're constantly looking at our surgical techniques and our radiation delivery devices and techniques and so on. The sort of the holy grail is to just find a pill that we could give people and say, this is going to make your tumor go away or prevent it from growing. There's some ongoing trials looking at things like aspirin. Interestingly, there's a biochemical reason why aspirin may prevent schwannomas from growing. But so far there's nothing, and I don't really conceive of something new happening in the very near future.
Okay. Do you one of the treatment, there's people asking about the facial nerve, and one of the treatments when you do surgery is to leave part of the tumor behind to preserve the facial nerve. And so the question is, are you seeing more regrowth? There's also a question about, does regrowth figure into quality of life issues? And another one asking if regrowth is possible when the entire tumor is removed, and why that's possible.
Those are all great questions. Overall, if you look at trends in treatment over time, if you look at all of the United States, increasingly people are leaving a little more tumor behind to save the facial nerve. And that's a difference in balancing priorities. It used to be that we thought that the diagnosis of vestibular schwannoma certainly meant growth and certainly meant eventual hydrocephalus and all these problems. But we've realized through natural history studies that a lot of tumors don't grow for periods of time and they're not cancer, so we don't treat them that way. So our goal in an operation is to maximally remove tumor while still saving the facial nerve and removing compression on the brainstem. Those are the overarching goals. But the priorities are that we would be amenable, or most surgeons are amenable or are okay with leaving a small amount of tumor behind if it's really, really stuck to the facial nerve of the brainstem. So when we look at our data, and also nationally, so for a very large tumor nationally, 40% of the time people are leaving tumor behind on a larger tumor to preserve facial nerve function. Overall, if you look at all of our tumors we do here, about 85% of the time we take all the tumor out, and about 15% of the time we leave varying degrees of tumor behind to protect the facial nerve. And that's a decision we make during the operation based on how stuck it is. Sometimes a very large tumor separates from the facial nerve very easily, and sometimes even a medium-sized tumor can be stuck. And so it's based on what we find during the operation. The risk of regrowth or recurrence after leaving tumor behind is directly proportional to two things: how much you leave behind and how long you wait. So if somebody is treated when they're 40 and they are going to live their average life expectancy of 85 to 87 years old, there's a very good chance that at some point, some of that tumor is going to grow because they have another 47 years to live. Mm-hmm. The other way to think about it is the more cells you leave behind, the more likely one of those cells are to continue to grow. And so the best way to think about it is if you leave a lot of tumor behind, or if you're going to live a long time still, there's a decent chance you'll require some sort of treatment afterwards. And again, the risk of regrowth is directly proportional to those two things. It's probably the easiest way to think about it. Mm-hmm. With regard to quality of life and regrowth, after you've had a treatment, particularly surgery, for a larger tumor, for example, a lot of times you don't have hearing, that your balance function's kind of gone and things. And so it doesn't change, a regrowing tumor doesn't change a lot of those symptoms, but it might affect how you think about it. And it might affect anxiety level or just your general or global quality of life, because you say, hey, I just went through treatments. I might have went through surgery and I had radiation, and now my tumor is still growing, which is a very uncommon situation, but can happen. And just knowing that might significantly affect your quality of life, but it usually is not through hearing or balance changes or something, because again, after those treatments, sometimes those functions are often gone after multiple treatments. Mm-hmm.
I think the really important thing underlying all that discussion is how important it is for patients to not get lost to follow-up. So we live in a very mobile society, and people move and so on. But I have to admit, honestly, we look at acoustic neuroma as a bit of a chronic disease. So even when we take the tumor out and we say we've gotten it all out, the MRI scan looks like we got it all out, the other aspect of that question was, can the tumor regrow even if it's completely removed? It can. We have seen that. It's rare. It's very rare, but probably it means one cell was left behind there. Or it is possible, because we try and leave all of that eighth cranial nerve, that vestibular cochlear nerve. So some people might have a genetic predisposition and get a second tumor. So it's important, particularly if the tumor has not been completely removed, that patients don't say, well, I'll only go back to the doctor if I get new symptoms. You need periodic checks.
Sure. Okay. And does that vary based on how long it's been since you've had surgery or treatment?
It depends a lot on how much tumor was left behind, if some tumor was left behind, how young is the patient, how big was the tumor when they presented. A young person who shows up with a really large tumor, we think has a bit of a more aggressive biology to their tumor. So we might follow them closer.
Gotcha. Okay.
The good news is nowadays with MRI, we have basically a no risk test to be able to follow patients. So it's obviously not much fun laying in an MRI scanner, but there's no risk to that test.
Right.
So.
Right. Okay. Well, we're coming to the end of our time, but I have one more question, and it's been asked a couple times on Facebook and then also in our webinar here, and that is: are there things that can be done pre-treatment to help quality of life outcomes following treatment? We talked yesterday again with Dr. Weiskopf and Dr. Deep about even doing vestibular therapy before treatment. But are there other things in addition to that that can be done?
Yeah, overall, we always say you should, depending on what you're doing, and particularly for surgery, you should enter it the healthiest you can be. If you do smoke, it's good to try to reduce that beforehand and exercise beforehand. Just entering any operation will allow you to heal quicker and adjust to it quicker. But with regard to other things, some people talk about doing prehab or rehabilitation beforehand, balance therapy. The problem is it's the abrupt change from the treatment that you're adjusting to. And if you haven't had that quote hit yet, it's hard to adjust to something that hasn't happened yet. Some people recommend it. And if nothing else, you're probably getting used to the exercises so you can continue them afterwards. There is this other thing called prehab with gentamicin. So uncommonly, but there are some groups, particularly in the Netherlands and Denmark, where they've actually given an injection of gentamicin to knock out the balance function before surgery, so you can adjust to that. And then you go through the surgery, and then you're only recovering from the operation itself and not also from the balance change. That is not commonly done. It has been done before, and it probably reduces the number of days you're staying in the hospital, but you still have to go through both of those things. And
right.
So it's not widely done, but that is one way to try to improve it. The biggest hit you take after surgery is the balance. You're going to be, for most people, not everybody, but most people are pretty dizzy for about 36 hours, 24 to 36 hours. And that really bad vertigo subsides quickly after that. Then they're left with this more general imbalance. It's not really vertigo as much for maybe a couple months, and that gets better. When do you really kind of get to your new baseline? Well, that's very different for every single person. But at about 6 months to a year, you're getting closer to where your new baseline is going to be. It's one of these curves you see in science papers and everything else. It's one of these curves where it's steep up front, and then it takes a long time at the end to taper. Where do you actually get flat? It could be a couple years, but most of the recovering is done in the first year, and that's your new baseline. There's a small percentage of people that don't fully compensate from their balance disturbance, and balance therapy in particular is really beneficial for that select group of people.
And I think it really goes back to what I kind of alluded to before, with Finland being the most happiest country in the world, is, be educated, know what to expect. And I think if you have realistic expectations, I think that'll go the longest way towards good quality of life.
Well, we appreciate you talking about this, because it's really important to be able to set those expectations and to be, to kind of know what, without being terrified, what the outcomes could be and what to expect following different treatments. So we really do appreciate that. Thank you very much for your time today, Dr. Link and Dr. Carlson, and thank you everybody for attending. We have 2 more webinars this afternoon, one at 5:30 Eastern, which will talk about hearing preservation, and then one at 6:30 Eastern time, which will be a panel of doctors. And I believe you are, both of you will be there.
Yep.
And we'll just answer questions for patient, answer patient questions. So we're excited about both of those things. If you want to get the full schedule of events, please visit our website at www.anausa.org and just click the slider on the homepage, and that'll take you to the page that has all the information you need. But thank you again for joining us, and thank you both doctors for a great presentation.
Thank you.
Thanks a lot for the chance. We got a lot of good questions on there. I'm sorry we couldn't answer them all, including some from our patients here. So thank you everybody for tuning in.
Well, we're holding on to all of these, and I'll have some of them this afternoon as well. So we can, maybe we can touch on a few more, but thank you so much.
Fantastic.
Thank you.